Right. Good morning, everyone. Happy New Year. Glad to be doing our first grand rounds of the year. Hopefully I'll set a good tone. Moving forward, I was talking to Dr. Gatt a little bit earlier, and we spoke about how I came about this topic. I'd first learned about the orthopedic surgeon's role in addressing amputation and limb deficiency in a talk that was given when I was a med student by Dr. Glenn Gasson, who's doing a lot of his group at Ortho Carolina is doing a lot of the work, kind of pioneering some of the things happening in upper extremity amputation. So, I hadn't had any talks since then, so I figured someone's got to do it. And I certainly learned a lot as I was as I was reviewing and researching for this topic. So thanks in advance for your attention, guys. So this is how we'll go through it. We'll go some historical perspectives, a little history lesson. We'll skip to the present day, and then we'll discuss kind of some of the branches of management of these patients in the context of a simulated case. So it all began, from what I read, it looks like people, as long as we've been sort of growing limbs, people have wanted to cut them off, whether it's for sacrificing or punishment and the like. This image here is from or said to be from 30,000+ years ago. Representative of sacrificial rituals of the digits. And we know about amputation in our field, but long before it became vogue in medicine, amputations were regularly used in other fields. One for part of rituals, as you've seen, commonly used as punishments for criminal activities. Hands were cut off for theft, tongues for lying. There's even one thing that said, they would cut someone's foot off, so gave them a Syme amputation for being lazy. So people have been getting creative with the technique for a very long time. Certainly in medicine, amputation came into vogue and into popularity very early on. Unfortunately, as we'll learn, although the field has had a head start, it sort of lagged behind in advances compared to other fields and other areas of medicines. But more recently, that's changed. Usually, people thought of amputation as sort of a last resort. It's very destructive, extremely high rates of complications. The place held by amputation, I think, is very well summed up by that quote. And I'd like to pull out the part that says, "So the patient may escape death or a greater affliction." So really, people thought of it as, again, the last resort, no hope. On the right here, we see sort of a depiction of an amputation circa 17th, 18th century. Prior to the advent of anesthesia, the operative experience was very different in that time. Wrong side surgery never happened. The PACU never called you to sign the patient. They would just tell you. The patient managed their own airway. There was no A-lines. There were no spinals. So anesthesia really couldn't find any possible way to delay the cases. So I think maybe it wasn't all that bad. But although slow, they were pioneers. Celsus, like in Rome, in about 1000 AD, sort of came up with the circular cut and came up with the idea of proximal division of the bone prior to leave a stump. Aryee and Petit are both credited in the 16th and 18th century with coming up with using ligatures as well as a stable tourniquet to prevent hemorrhage and excessive blood loss. And Young in England in the 17th century described using a flap of skin to cover the bone, kind of akin to what we do today in amputation. So probably some of the most significant improvements in the field came from wartime. So a better understanding of resuscitation, aseptic practice, anesthesia, tissue handling, all these things, prosthetics, early post-traumatic care, all came about, and so many other things sort of kind of shoved the field of amputation surgery from the dark ages, literally. So I think all those improvements were crucial to getting us where we are today. But one of the threads I want to touch on, and this came about between World War I and World War II, was sort of this prevention, the focus on prevention. And so this is trench foot, disastrous complication of wartime. People, the Allied forces would be in water, standing water for hours to days even, and tens of thousands of men lost limbs due to this disease process. And so between World War I and World War II, the paradigm shifted from treatment with amputation to sort of prevention with better wartime practices, improved footwear, which are all greatly reduced the rate of limb loss in the subsequent war. So this is sort of the first time that prevention became a mainstream thread in the discussion of amputation. So recognizing that the focus today will be on pediatric considerations in acquired limb deficiency, a discussion of prevention is of course extremely crucial, and I'll talk more about that in just a bit. One thing I wanted to highlight was that historically, amputation and the advances in the field have always been focused on adult care, right? So most of the advances in pediatric care of amputees have just trickled down from the adults, and I think that's really for two reasons. One, there's a tendency to think of kids as small adults, which you spend any time on the ped service, you realize that's a good thought, but misses the mark. And we'll take a more formal dive into that in a little bit. But two, eventually the kids become adults. So some of the thinking is, well, if we can sort of give them something that's good enough, maybe to bridge them, they'll be adults. And so why reinvent the wheel of all these prosthetics and all these advances? But again, a good thought, but I think it misses a mark because yes, they'll become adults, but for some kids, that may be a decade away from the index trauma. And moreover, we have the know-how. So, and you'll see kind of some of the amazing things that are being done in the field. So I think it's just plain unfair to the kids. And finally, the way that kids use use prostheses and learn to use them at a young age really affects how they use them when they're older, and things like prosthetic rejection come into play. So I think it's just, we can't neglect that. So what I'm going to do today is I'm going to put the spotlight on the kids and give them the mic, whether they're sort of ready for that attention or not. We'll see. So how often is this happening? I read in a study that, all comers, major and minor amputations, lower and upper extremity, there are anywhere between 2 to 18 and 100,000 kids are having these amputations. I'll quote 2 for us today, kind of the low end of the spectrum, we'll say 2 and 100,000 per year. So that's nothing, compared to the incidence of something like ankle fractures. Of course, pales in comparison to the incidence of carpal tunnel syndrome. But I was thinking of things I've had a lot of lectures on, and compartment syndrome came to mind. And surely that happens a lot, not as much as ankle fractures or we'd be in trouble, but definitely more than pediatric amputations, you'd think. And there was a study citing kind of data from the 2000s that for all causes in the Western world, they were saying something like 3.1 per 100,000. So to put that in perspective, it's not that much of a difference. Certainly it's more, but I can't count the number of compartment syndrome talks I've had, but I've never really had a peds traumatic amputation talk. And so, I think that based on the numbers, compartment syndrome may be getting a slightly disproportionate share of the press. So I'm here to sort of right that wrong this morning. Beyond the numbers, we want to think, okay, what are the etiologies? The first one I'll go through is other, and I'll sort of go through these ones quickly. Others, kind of like this mixture, amalgam of medical disease that leads to limb loss in kids. So things like coagulopathy, infection, or others that may become limb threatening if left unchecked. And this is an image of purpura fulminans. It's a sign of DIC. You can see with meningitis, for example, and it's a common cause of limb loss in kids and adolescents. The next up is neoplasm. Again, going quickly. Malignant tumors are probably the second leading cause of acquired limb deficiency, twice as much as medical disease, at least 2 to 4 times as much. Osteosarcoma, Ewing sarcoma are the major players. And the incidence of these amputations are coming in adolescents. And the last big one, kind of the largest swath, what we'll focus on today, is trauma. So we'll break things down into a few categories. I draw the data from the next set of images from a study in 2017 about the trends in amputation. So first, as we'd expect, young boys outperform little girls in getting in trauma and getting amputations. They account for about 2/3 of the amputations. By age, children under 5 probably comprise the largest swath of patients sustaining amputation injuries. Now, these are by and large minor amputations, right? Digits and thumbs. From low energy mechanisms, getting caught indoors or caught between objects, with only about 10% of these patients requiring hospitalization. The next large chunk comes from school-age children, and these tend to be also lower energy injuries, things like MVCs and major crush injuries start to become involved. And then finally, the high school age children. These are probably the largest single group of kids sustaining traumatic amputations. And these are more major injuries. About a quarter of these were requiring hospitalization. These are high energy injuries, explosives, weapons, firearms, farm, and work machinery all come into play here, just given what the kids at this age start having access to. And how exactly do they do it? So far and away, I caught my finger in something is the most common cause of amputation, usually digits again in kids. The dreaded lawnmower, the blade always stops. You always have to reach under for something. Pro move, don't reach under for anything under the lawnmower. It's about 12% of amputation in kids. Farm and work machinery, like large presses, take up about 15%. All things MVC, so whether that's being in a car accident, getting hit by a car, all these things end up being about a quarter of the amputation injuries. Fireworks, explosives, firearms, and sharp laceration. And then the final group is sort of kind of this, again, this mismatch, this mishmash, hodgepodge of electrical shock, household appliances, and landmines in other countries actually that were formerly war torn. So what do they lose? Thumbs and fingers, more than half the time. Toes, probably about 20%, they said. Foot, ankle, and around the knee, about another 20%. And then kind of the smallest percentage of this group, what we'll discuss today, are things above the hand. So I just wanted to sort of slow down and briefly talk to us here, help us recognize that the last 10 or so minutes, probably all preventable, right? This is all accidental trauma, and that's the leading cause of morbidity and mortality in children. It's often preventable. The interventions for preventing this kind of thing range from simple, things like locking firearms or the key to locking up the keys to power lawnmowers, or even more complex things like enacting laws for child seat use and regulations across the state. But the sentiment for all those things remains true. And the idea is that prevention is far, far better than cure. So if the appeal to ethos doesn't do it, let's talk about the pockets. And I think during every discussion about the burden of disease in the United States, you have to talk. There's always something earmarked for the dollars and cents. You have to talk about it. And quite frankly, I don't think that you've told the entire story until you've at least mentioned that. So there's a study published in 2005 in Journal of Trauma, Injury, Critical Care that examined a nationally representative sample of pediatric patients. In their study, the demographics were rough. They saw that about 75% of these kids were boys. They were mostly finger and thumb. None of these patients died from their injuries. So similar to sort of some of the demographics I presented earlier. And what they saw was that some of the highlights, at least, were the average hospital stay was less than a week. Okay, the average cost was in the tens of thousands for treating these kids, and then the annual burden in that year, 2003, they said was $21.6 million. They were estimating. I think important to remember is that this database only looked at children who were inpatients. So that tells us that one, these weren't very minor. These were at least something that required a hospital stay. The study, though, didn't look at costs for anything that happened after the index admission, or the index hospital stay. So prosthetics weren't taken into account. The cost for readmissions for complications, for example, all weren't taken into account. So I think that these numbers sort of represent only a small piece of the pie, right? So inpatient care, readmission, the cost of prosthetics, and then there's sort of this large gray question mark, and what goes there. Things like home modifications, psychiatric care, disability costs, readmissions, and so many other things that are just so difficult to cover or capture in a single paper. So, I think in short, the burden of this musculoskeletal disease is real, and it can be very high impact. So, before any disaster consult comes in, it's always a little too quiet, right? The pager's been empty for days. It's singing to you now. We're getting joke pages. So as forward-thinking residents who just had a grand rounds on this topic, we do a thought experiment, right? And we say, okay, if a traumatic amputation in a kid just rolls in, who would want to be on your team? So we're going to cheat. In this case, we're going to kind of have a little bit of forward thinking, and hopefully a small crowd here live, but hopefully we can have some participation. So first up, a physical therapist. Yay or nay, guys? Do we want to keep or leave this person? And they're saying keep. Perfect. Next, a psychiatrist. Okay, Andre's quickly nodded yes, so we're certainly going to keep him, Chief says. All right. Next, Dr. Levine, right? It's a hand surgeon, right? Upper extremity, we keep him. All right, so everyone wants to keep. I'm sorry, but there's a caveat, right? And he comes with all of our interns, and Jason is asleep the entire time. So I think that may change our minds. They're only so, I think this graphic here only has 6 lifeboats. And so I'm sorry, Dr. Levine, and our interns, but Dr. Belika, right? She comes by herself. She's a pediatric hand specialist. And we're in a pediatric upper extremity talk, and she'd beat me up otherwise. So we're going to keep her. And then social work, right? These kids are going to have to navigate a lot of different spheres. We're going to have them, our prosthetists and our orthotists. That's Joel. I couldn't get a picture of him. I'm sorry, guys. But we'll keep them. And Dr. Ustal, right? So he's in PMR. He's someone who works a lot with our amputees who need prostheses. So sentiment in the room, survey says we'll keep them. Sorry. So going away from sort of the gimmicks, the point is that the team has to be deep whenever you're planning for pediatric amputation patients. Sort of the role of the surgeon is clear and critical, but limited. We're the first persons to meet the patient often. We decide between limb salvage and amputation. Our knowledge of upper extremity and all these things are an understanding of the dynamic skeleton are super important in decision making for this child. But once the dust is settled, our job it's not done, job's not finished. We have to, the immature skeleton causes us to end up having very longitudinal relationship with these kids, unlike in the case of some of our adult counterparts. And I think that beyond what the surgeons do, there are hours and hours and hours of that has to be done of training and work that has to be done to sort of teach these kids how to learn to live with the new limb deficiency. And so, early interventions in prosthetic rehab, physical therapy, psychiatric care are critical for good outcomes in these kids, right? So the pediatric physiatrist has a role. They coordinate with our PT, our OT. They also coordinate with who are going to be seeing the children and giving feedback and insights from direct interaction with them. But beyond that, right, the physiatrists also work with our orthotists and our prosthetists, and their knowledge of the capabilities and the limitations of different prostheses, as well as their knowledge of the different developmental milestones that kids have to go through is going to be crucial. And then again, our psychiatrists, their role, I'll go into a little bit more in the future, but later on in the talk, but their role can't be overstated as well, sort of in the setting of trauma, right? During emotionally trying time in a child's life, like adolescence. We all remember being teenagers. And so I'll discuss their role a little bit more deeply later on. Okay, so you get this page, right? So trouble's here. So we're in the case. You call back 1-800-HELP-ME, and the team says, I have a trauma here in the bay. This kid has an elbow lac. We can see the bone, right? So any other information we may want. And so the room is saying literally anything. So, right, so we get the age, get the mechanism, we get the laterality, we get a little bit more. It's an isolated injury, multiple open fractures. So it sounds bad. So we're gonna, we'd ask them, please, finish the trauma survey, get the scans, give antibiotics, x-rays, tetanus. We start walking down to the bay. And on our way down, we start thinking, okay, this might be surgical. We start thinking, okay, well, this is a kid. This isn't something that we may see a kid in extremis as often. So we have to start thinking, what are the ABCs for kids, right? Smaller airway, their heads are bigger, their cervical spine needs different care. B, breathing. Kids are going to have inadequate ventilation very often. They fatigue more easily. Circulation, they just have a lot less blood to lose. What's this kid's hemodynamic status going to be when I get there? And so, we start, things are very, very different than a lot of times with adults, which we see very routinely and things that we have practice with. So I think, you're already, this idea of mental gymnastics, I'll go over a lot of times as we're going through the case, but we get to the bay. The kid is hysterical. And other than transient hypotension early on, they gave blood. He's feeling better now. He's stable. And so this is the kid's arm. So we do an exam. It's not good. The kid is hysterical, as I said, but we can find out that there's no sensation below the elbow. He can't move the digits. You can make out kind of maybe a faint brachial pulse up top, but where you think the elbow is, there's nothing below it. And the fingers are blue. So you clean yourself up and you call Dr. Blica, who happens to be on call. And you tell her kind of a more cogent story. So we have a 12-year-old male. He's right-hand dominant. He has this mangled left upper extremity. He was playing with gardening equipment, unsupervised, and he got his arm caught in the riding mower in the barn. He was pinned for over an hour before anyone could get to him, before he was found. He's stable in the bay. He's gotten all the antibiotics, Ansefgen, penicillin, tetanus, and his arm is insensate below the elbow. He has no motor, no. It's cool and pulseless. And you send her these X-rays that they were able to get. So it's terrible, right? So you wash it out. You covered it in zero form. You put on some semblance of a splint, and she tells you, "Okay, classic case. We're going to go upstairs." So as you're setting things up upstairs in the OR, Dr. Blica starts to give you some of the pearls and discusses some of the literature to help you sort of understand the plan of attack in this case. And so first thing is what's happening, right? What's the damage? So the definition of a mangled extremity is one in which 3 of the 4 major tissue types of bone, soft tissue, the nerves, the vascular structures are injured. We have 4 out of 4 in this case. So we have a limb-threatening injury here. And we've sort of arrived at a fork in the road, right? So we have to decide, are we gonna be able to save this arm, or are we gonna have to do amputation, right? We're gonna have to measure twice before we cut once. So I think in general, the dogma is that the upper extremity does better than the lower extremity replants, right? And we see that, right? The form, and there's this adage that a bad hand is better than a good amputation. And so certainly the former is true, right? The anatomy of the hand, and as well as the function of the hand, helps to change the way that you use it when it's replanted. It helps to change the outcomes in this patient, right? So there's great circulation in the upper extremity. Patients tend not to have sort of baseline ischemia in the upper extremity, and so that helps to prevent from critical ischemia and give us more options for, and there are more options for revasc in the upper extremity as well. The idea of walking on an insensate foot, I mean, that is something that would certainly cause a lot of the complications that we see, whereas the hand can be directly visualized through most of the day. So you don't end up having a situation in which you're subjecting the upper extremity to the same abuse as the lower extremity. So they tend to fare better at that for those reasons and several others. So there's a lot to consider, right? The factors influencing salvage or amputation are myriad. Often we look at things like the MES score, for example, right? The score is based on ischemia, soft tissue injury, global perfusion, as well as age. And for our kid, if we sort of calculate it up, he has a MES score of 8, remembering that a MES score of 7 is predictive of amputation. But there are issues with using the MES score, right, in general, and in this case. For one, it was developed in the 1990s. So, some of the advances in and techniques that we use today in amputations, as well as in limb salvage, probably unrecognizable to the group at Harborview that originally came up with this MES score. There was a study in 2017 talking about, the MES score and reevaluating it. And is it time for a revision? Very funny. They found that a MES score of 8 only predicted a need for amputation 43% of the time in this sort of retrospective look at things. And once they controlled for confounders, they couldn't actually tell the difference between the patients who needed amputation versus patients who didn't. So they didn't think that it was useful or very useful. And beyond that, in our case, it was used in the lower extremity. So it's really not. It's kind of apples to oranges if you're going to use it in this case. So messes out. More recently, though, there have been scoring criteria for the upper extremity injury on the horizon. So this is by a group in New York at NYU, and a while they developed this sort of Mangled upper extremity score, the Muse score, in 2019. It was based on a retrospective review of 76 patients with mangled upper extremity injuries, and they sort of came up with 8 criterion: age, need for fasciotomy, and several others. And for them, what they saw was that patients who failed salvage had a significantly higher Muse score, right? And a score greater than 6 was 80% specific, 82% specific for the need for amputation. So, this is something that's a little bit more recent. And what they said in their conclusion was that when you set thresholds like this for the MES or the Muse, there's the idea that the threshold is flexible based on the salvage capacity of the institution that this injury comes up to. So for our kid, based on the case, he has a MES of 8, he's a Muse of like 7, and so it's not looking good, right? However, there's still an issue with both of these studies, the MES and Muse, and the idea is there for adults, right? So I'm sure that these the studies exist, and they're probably great ones, but I really couldn't find any that I felt comfortable standing on, and I think really there just hasn't been this just hasn't been terribly well studied in this population. So, but I think based on principles, understanding of ischemia in the limb, the damage that we saw, the exam of our patient, we decide to move on with amputation in this child, right? And so another brief pause. I think that there's this idea, right, that amputation is sort of ablative, right? You think of it as a failure. You weren't able to save the limb. We couldn't salvage it. We couldn't do it. And look at who does a lot of the amputations, right? It's often pawned off, quote unquote, to the junior most residents, right? People with the least experience. I think that sort of, and I hope after this talk, maybe we can sort of rearrange that schema we've built around amputation and think of it not as a failure, but or even a last-ditch effort, but sort of like the correct treatment in some cases. And in pretty much every amputation, no matter how minor, you're going to change the course of someone's life. And so, I think that if you take care, it can often be for the better. So, food for thought. Okay, back to the case. So, the namesake of the talk, we decided to proceed with amputation in the amputation shocking. And the first fork of the road is, what level will it do? So, sort of in determining the amputation level, the goal is to create the best environment for rapid return of function and mobility. Right? So in general, we always try to leave as much of the limb as possible, right? As much viable tissue as possible. Our goal here is to determine, what's the most distal level that's good and compatible with wound healing. So before we go into that, I want us to talk about some of the things that some of the mental gymnastics we have to do because we're dealing with a child in this case. So with diaphyseal and metaphyseal amputation, right? In the case of this, what's the most important thing that we have to remember for kids that we don't have to remember for adults that their bones do? They're growing, right? So our med students are helping me out here. They grow, right? The skeleton is dynamic. And so for transhumeral amputations, the ideal bone section is 10 centimeters proximal to the joint at end of growth, right? 14 centimeters distal to the olecranon, right? If you're in transradial, but you can't just make the amp at that level in these kids, right? You still have to grow. So the first important thing is we need to understand and account for the differential rate of growth of the different bones. And so sort of where the gymnastics comes into play. I did the work for us, don't worry, but given context, we have a 12-year-old kid, is maybe 4 or 5 good years of growth left. The humerus is 20% of standing height. I didn't know that. And the radius to put the forearm is maybe 15%. And so if our kid is going to be 5'10". Shout out to our short kings. Then we want the humerus to be 25 centimeters at end of growth, and the olecranon, or pardon me, the radius and the forearm to be 14 centimeters. Right. So I'll spare you guys the trouble and just take my word that we want the humerus to be 20 centimeters at this cut, and then 13 centimeters for the forearm. So not very much off of the mark, right? We can see that we'd leave only 1 centimeter for the olecranon, but 5 centimeters here, it grows more, we know that. So there's a lot more to consider though in major amputations. I think one is something that Dr. McPartland quizzed me on as I was standing here. He was over there in the corner of the room, and he asked me about overgrowth in a child who had a femur fracture, and my answer was overgrowth happens, and it does. So overgrowth is a significant cause of morbidity in pediatric patients with traumatic amputations. Right, the skeleton is immature, and we know about the remodeling potential and regeneration potential that kids have, and so for a long time, people thought that it was due to the physis, actually, that if you closed off the physis in these kids with amputees proximally, the bone wouldn't grow. They saw that that wasn't the case. In fact, it's due to the overgrowth here is thought to be a mix of endosteal and periosteal growth in the setting of the amputation, which sort of creates an osteogenic environment that kind of hijacks growth and regulated growth in these kids. And so this happens, right, in our traumatic amp. So what do we do? The answer is, or what people have found is that you can cap the end of the bone, right? So there are several options. I pulled up this paper here. Dr. Bullock and I talked about another case where they used synthetic capping. So it seems that at least I didn't look very granularly at it, but from what I saw, sort of from 10,000 foot view, there are many different options, and it sounds like they all have relatively good success. The idea is you just need to cover that traumatized bone, which can help to prevent that, again, hijacking and overgrowth, and puts it to a near halt. So for our patient, I think that for sure we'll have to do some sort of capping, right? I think that's the right answer if we're doing a diaphyseal amputation. Okay, disarticulations, right? So the precious physis. I think it's the physis to the rescue in this case, right? It's a little counterintuitive, as I mentioned before, but when you have the active growing physis, when you preserve that, overgrowth doesn't happen, right? Things sort of grow in proportion, right? The surrounding soft tissue and all the bone, they move in proportion. So whenever it's possible in kids, at least people try to do disarticulation as opposed to metaphyseal or diaphyseal amputations, right? The flip side to that coin is that sometimes prosthetic fitting can be troublesome around the elbow, especially. But I think given the opportunity to avoid the complication of overgrowth, and prevent, kind of alleviate the need for revision surgery on revision surgery on revision surgery, I'd take that now, and then we can worry about sort of fitting prostheses and custom prosthetics later. So looking at what our patient had from the gross imaging, and sorry, I didn't put the image here, but in your mind's eye, sort of remembering what that bone looked like, I don't think that disarticulation at the elbow or anything distal to it would be possible, honestly. And so from here, we're going to just assume that we're dealing with a transhumeral amputation, and it's 20 centimeters. It's a perfect length, fortunately. So once you determine the level, we have to decide what we're going to do with the residual limb here in this case, right? So the nerves. Nerve management is tough for amputees and surgeon. There are over 100 different ways that people have described managing the nerves, right? So there's proximal transection, right? There's cautery, right? There's the adage that you never see neuromas in a burn unit. And so perhaps there's something to that. You can bury the nerve in the bone, you can bury it in the fat, you can bury it in the muscle. Anywhere you can think of burying it, someone has put it there, to try and prevent painful neuromas and phantom limb pain. But what I've learned in residency is that whenever there are kind of like 10, 15 different ways to do something, and no one actually knows what to do, what works, right? And there's probably no difference in all of these. So I want to introduce some of the newer techniques though for nerve management. TMR, targeted muscle reinnervation, and RPNI, which is regenerative peripheral nerve interface. have been, or we can call neuromodulation techniques, have been getting a large share of the limelight recently, and the popularity is picking up. So here's what I found in this very newspaper, actually, that this kid is holding. So it's the future of amputee care. Right? Neuromas are a thing of the past. Right? Coming to an OR near you. There was one quote that said, "Not just an obscure hand procedure." Hand surgeons, cautiously optimistic, good science. So there's been a lot of buzz about these, and so sort of to help us understand, we take a trip back to basic science, right? So whenever they're cut or damaged, the nerves heal by Wallerian degeneration of the distal segment, and then axonal sprouting from the proximal segment, right? And so the idea, kind of glossing over some of the specifics, the idea is that these axons are trying to regrow along the old nerve path to the end organ, which is the muscle in this case, right? So, and then you end up here. But if a nerve can't heal, all right, towards an end organ, right, there's nothing to guide the growth, which is exactly what happens in an amputation, right? The end organ, the muscles are all gone. You end up with sort of dysregulated growth, improper neural firing, and the neuroma, which is painful, right? The dreaded neuroma. So what do we do? So all of these things, TMR, targeted muscle reinnervation, RPNI, are all sort of neuromodulation, specifically their physiologic target reassignment. And so what they do is they allow us to sort of think of the normal healing patterns of nerves, and then take control of those, and we provide an avenue for normal growth. And so we sort of kind of usher the nerves into an area where they're going to grow normally, as opposed to in a dysregulated fashion. So in targeted muscle reinnervation, right, the free nerve is hooked up to a recently denervated muscle via nerve transfer. In RPNI, which I thought this was cool, it's sort of, it's burying the nerve and muscle, but in this case, it's a denervated, it's a free flap of muscle, and that seems to have been working and been very promising recently. And then the TNI, it's very similar to the TMR, where the TMR is probably more like a true neurotization, where it's now the only nerve going to that muscle, where the TNI, so you can take one of the branchlets of a distal of a motor nerve, and you can sort of plug the other nerve into it, so it's kind of borrowing space as opposed to hijacking the entire muscle. So, and the principles are simple, right? Devil has worked for idle nerves, so this is sort of the idea that the nerves left to their own devices are going to form neuromas, and so if we give them a job, they're happy, and then coordinated, regenerative growth is good, dysregulated growth is bad. And I think, again, that's sort of along the same lines of kind of controlling and guiding the nerve to regenerate properly and not be dysregulated. And the last here is just is a little bit kind of to the side, but pointing to the idea that nerves regrow, the environment in which nerves regrow is important, right? So if we're going to do an amputation for a trauma or even a cancer, where we're sure of the zone of injury and we know we can be proximal to it, perhaps we can do TMR or these neuromodulation techniques in acutely. Whereas if we're dealing with someone with severe burns or infection, where the exact zone of injury just hasn't declared itself, well, then we probably want to think of doing. We want to wait, and we found that it doesn't affect the outcomes very much. So all that's in theory, what's been published. So Alexander and et al. In this group out of Ohio looked at a small group of 58 ONC patients. They did 31 of them had TMR primarily, and they found that this group had fewer and less intense neuromas, better pain scores, better residual limb pain scores. Valerio and some of the same group out of Ohio actually compared TMR in 51 amputations versus kind of a large population they surveyed. And these patients, they had better day-to-day pain, they were less painful, they had less pain behavior, they had less pain interference with daily activity, less all these things, very, very positive. Souza and a team from Chicago, again, they did TMR in 26 patients with transhumeral amputations and shoulder dysarticulations. 26, they did in 26 patients. 15 of the patients actually had neuromas before they did the surgery, and 14 of the 15 got better from their remote neuromas completely, and one had kind of partial resolution. A group from Michigan did their work with 90 patients. They had 104 total amps, and they did RPNI in these cases, and they compared them to standard methods. And like these guys were seeing things like 0%, like no neuromas in their RPNI group, and they almost halved the incidence of phantom limb pain. So this is sort of just a random smattering of things. So very positive for right now. So if we're going to do TMR for our kid, that's what we decided. We're going to cut them short, and someone runs into the OR. They show us all these papers, and they say, you know, this is what we have to do. And so we say, okay, let's give it a shot. So we sort of have to think, it can't hurt, right? And there's a lot we have to decide, right? Who are the players in this game? And so I'll just sort of go through it. So the nerves here, right? We're distal to the brachial plexus, right? Thinking of them with the median nerve, the musculocutaneous, the ulnar, radial nerve appears twice because it gives off a proximal branch in the arm, but it also has innervation distal, right, in the forearm. And then we think about the muscles that are at play, right? The biceps, long head, short head, two heads of the triceps and brachialis. And usually we don't include the third head of the triceps. It's not used in or not needed in these cases. So, all right. So which one of these are sort of just still hooked up, and which ones have distal innervation, right? So the median nerve, the ulnar nerve, the radial nerve, distal branch, right? These are the three that are sort of flopping in the breeze, quote unquote. And these two guys are controlling everything, right? So essentially what happens, it's a simple rearrangement, right? And give everyone a home is the idea. So we'll keep the musculocutaneous nerve with the biceps short head. We'll keep the proximal part of the radial nerve with the long head, and we'll cut all the other connections, right? And then we give those partnerless muscles a new partner, right? So it sort of comes along something like that. And then this is what it'll look like, you know, visually, nerve-wise. So the loosely hanging nerves are now the median, the ulnar, the distal part of the radial nerve are now anchored into a home. They're far, far less likely to give us neuromas. And moreover, we're set up to receive the latest and greatest in myoelectric prosthesis, which is something I'll discuss in a little bit. Then what do we do with the bone, right? So we sort of talked about it already. There are a lot of things you have to consider: the dynamic skeleton, right? Calculating starting final length, the mental gymnastics, end capping, lots of things there. But something I wanted to discuss that I sort of came across as I was reading was this idea of osteointegration, or the transcutaneous implant. Pretty cool. It sort of came out of some studies done with rabbits, as well as some of the knowledge we've gained from excuse me, from dentistry. And osseointegration essentially is a procedure where they implant a metal, like usually titanium. It's directly anchored into the residual bone, and then there is an abutment that sticks out of the skin from the bone that goes into the prosthetic, right? So they're sort of like the small connector, and that eliminates or obliterates the need for a socket, right? So there are a few systems, 6 so far. OPRA system is the oldest. It uses a 2-stage procedure. The first is where they drill and ream and anchor that piece in the bone. So that's the B X-ray, and then the C X-ray is 6 months later. They come back once that implant has integrated, and then they attach the abutment that's going to stick out of the skin. Then they deal with the soft tissues. They close the implant over they close the skin over the bone, and they leave that small area, that stoma, and sort of a few months later, so this is what you get. It's sort of this thing, right? It takes like 10 seconds to put it on and off. So pretty neat. So we have this cool technology, intuitively makes sense, right? So what do the patients say? And the majority of patients improve both subjectively and objectively, right? The quality of life scores, the PRO and outcome scores are improved after osseointegration. 6-minute walk test, the timed up and go test, the oxygen use decreases. The patients are more their walking appears more like non-amputee patients, and people started describing the prostheses as, quote, a part of me. And so that's where this idea of osteoperception comes in, where the direct mechanical stimulation that you get from the prostheses abutting the bone sort of gives you a lot more information about your surrounding, gives you a lot more information about where the prosthesis is in space. You can feel vibrations, you can navigate uneven ground a little bit differently. And so it really, people are wearing their prostheses, their wear rates up to 90% with these. And so people are saying, again, it really does make it feel like a part of you. But there's no rose without a thorn. And you have this thing that gets people active and moving again. And so if people spend enough time walking around, someone's going to fall and break something. And so fortunately, so far so good with periprosthetic fractures. The study talked about 500 fractures globally, which is probably, 500 implants globally, which is probably at the time of publication nearly all of these implants that were out there. And they found 22 periprosthetic fractures. All of them were in the lower extremity. All of them were intertrocks or subtrocks. They were all fixed with DHS or recon plates, and all united, and none of the implants had to be removed for fractures. So the sequence here is sort of 64-year-old female. She fell at this periprosthetic. It was repaired with DHS with a recon plate combo, and then she had the plate and screws removed a year later, and the prosthetic never had to change. Per report, she's still a community ambulator, and she still uses her prosthesis more than 16 hours a day. So pretty awesome so far. The other ugly thing that you have to worry about is infection, right? We have a direct track from the bone out to the air. Unfortunately, so low-grade infection happens about a third of the time from the few studies I read. However, infection requiring some sort of intervention was on the order of 5 to 8%, and then infection that and even the group of patients who had to have their implants removed because of infection was an even smaller sort of fraction of that 5 to 8%. So I think that as this is something that's still relatively new, as sort of the technology and the knowledge about the bone skin air interface improves, I expect those numbers to change and decrease. But the caveat being that these are sort of selected patients, right? So selection bias is going to be a large part of why these patients are doing so well. This isn't your everyday, vasculopath or diabetic patient who has terrible limb flow, and so I think that these numbers will sort of oscillate as it becomes more available to the public and as our knowledge improves. So for our kid, what's the data for upper extremity? And I couldn't find a ton, but this study here looked at 37 patients who had them in the upper extremity. This is 2011, it was published, and they found similarly very few reasons to remove the implant. And I think 2 of the patients who are transhumeral patients didn't use their implants anymore. One was because of failure of the integration, and the other was because of a shoulder injury that's unrelated to the implant. So so far the results were good, but early on. And I think the relevance to our patient is that in kids, actually, they don't use these just yet because not enough is understood about the way that the residual limb grows in kids and how the osseointegration will change. They're still growing. There's still so much that's happening and too many variables. So kids haven't gotten these. But I think in a few years, when our patient is sort of knocking on the door of this technology, I think a lot of advancements would have been made by then. And I think that, in fact, this is something that'll become available to him and probably to everyday users. So, prosthetic design. Another sort of an exciting area of amputee care and talking about amputations is the idea of looking at the prosthetics available, right? So the types range from simple to complex. Simple, kind of like what we see in this cartoon here, and more complex things, right? Each has their own upside and downside, and in line with the theme of being dynamic and mental gymnastics, and sort of thinking in children, we have to think about the changing size but also the cognitive capabilities of our patients, and those will sort of play a role in the choice of prosthetics. Passive prostheses are the first things that I'll talk about, right? There are several ways we can break this down. So I decided into these three large groups here. I thought this is the best for kind of looking at the options as well as understanding them. So I'm creating a framework in your mind. So looking at passive prostheses, as the name states, these are the most basic type. They don't produce active motion at all. So they're lightweight, they're more realistic appearing, right? And so they're further subdivided into simple or static, and adjustable, where adjustable prostheses are ones that you can move in space, right? Usually a pincer in the hand and flexion extension at the elbow, and you can use them to hold objects or gain leverage in certain scenarios. So that, and then these can be used in kids as early as 6 months. So they're simple, right? And they're light, and sort of essentially once the kids have started to sit, if unfortunately you have a amputation that young, the idea behind using them in kids that young is twofold. And thinking is when the kids are young and they use prostheses, they're more likely to use them when they're older, right? And so sort of you can think of them as sort of like a placeholder in that case. And the other is that having a prosthetic encourages symmetric development, postural alignment, and bimanual function and dexterity. So kind of the idea of even just transferring an object from one limb to another is something that, if you haven't learned it, or if you don't practice it, it's something that can be forgotten or lost. So next, we'll talk about the body power prostheses. And so I draw this line here to sort of delineate the passive from the active prostheses and devices that can produce motion on their own without you directly touching them. So we'll have a short clip to sort of just explain how the body power prostheses work. Right. And so in the event, I'm not sure if everyone is able to hear that over Zoom, but the idea is that using your own body motions moves those cables and levers, which again produce joint motion. And then to switch from one joint to the other, you kind of have to do a special maneuver, and then you can control the hand separately from the elbow. So you get to use one at a time. So the main barrier to use for kids is they're heavy, right? They're bigger than those small plastic hands. And it requires kind of some amount of cognitive processing power to use them and understand that mechanism. So kids don't really start using these until age of 2, maybe a little bit before, maybe a little bit after. And of course, sort of at this age, the device needs to be changed frequently, right? And to accommodate the rapid growth. So, I think as our friend said, they're better than nothing, but not the best, right? So you can have motion of the prosthesis without touching it, which is greater than having to, right? With a little training, things become seamless, the way that you move your arm and move your elbow and hand. But you can only move one joint at a time, right? And the motion in the hand is very primitive, right? Compared to a true hand, right? So it's simply a pincer, which is probably worlds better than nothing. But certainly nothing compared to the 20+ degrees of freedom that you can get in your hand and wrist. So better, but not the best. And then finally, we'll dive into the externally powered prostheses. This is some, for the most part, I'll talk about myoelectric prostheses are most interesting of this kind, and some of the most cutting edge DME that you can have. It's the stuff of the $6 million man here. And so myoelectric is one that uses, is any prosthetic or device that uses EMG signals from a muscle, generated from a muscle contraction to drive the action of a terminal device. And so it's still awesome that, every time I think about something like this, you can do this for people. It's pretty awesome. So these prostheses are usually far more cosmetically appealing, then the harnesses of the body-powered prostheses, right? And as the technology has advanced, and I'll go into it a little, people have developed ways that you can have more degrees of freedom, right? You can control digit by digit. You can have proportional control, so you can sort of determine how hard you want to open or close, for example. And then people have even implanted afferents, so you can actually feel the prostheses. But there's a catch, right? There's always a catch. And in this case, that's upkeep. So, the batteries, they're heavier, they're easier to break, right? They're expensive, they're not waterproof. And so, and moreover, they rely on the skin electrode interface, right? Which to pick up those EMG signals. And so that can be fickle, right? I mean, something as simple as sweat can cause that to break down. Scar tissue building up over the residual limb can cause that to break down. And moreover, it can be tough to learn. And I'll sort of go into the specifics of kind of the different ways that you can control them. But sometimes that difficulty of learning can sort of pose this sort of insurmountable barrier to use of these devices. So traditionally, direct control is the way that these prostheses are controlled. And so what that means is a single muscle sends a single EMG signal, which controls a single motion, right? And so for example, each of these nerves are plugged in, right, to a muscle, and each one sends a signal, and that produces a contraction, and that causes a specific motion, right, as depicted on the screen here. And so to produce a motion that's not attached to one of these muscles, right, usually you have to do some sort of unlocking motion, sort of similar to what we saw with the body-powered prostheses, right? So to do pronosupination, for example, sometimes you may have to try to contract the biceps and the triceps, flex and extend at the same time. And then the device knows that now you want to try and rotate the arm, and then you can't open close, for example. So that's tough and understandable why people might not be, able to get that early on or get how to use these and work them, and how they may think that they're, although amazing, cumbersome. And so to combat that, they've developed something called pattern recognition. Right, and so we'll play a short video here. And so it takes information from a set of muscles. I'm sorry. So essentially, it takes information from a set of muscles. So when you think, open my hand, right, the nerves fire differentially, and it understands that differential firing, and then it locks that pattern in as whenever the user thinks this is what that means. And so that's far more intuitive and certainly easier for a lot of our patients. And then the last thing, right, sensation is vital to limb control, especially in the upper extremity. Sort of without it, sort of amputees have to kind of directly visualize, right, their hand. They have to look at the prosthetic. They have to think. They have to see how much they're squeezing something, for example, under direct visualization. So sensory feedback has actually been introduced to these devices by introduction of pressure sensors that are used to stimulate peripheral nerves of the residual limb. So they sort of have pressure sensors on these devices and then actually plug that into the sensory nerve. So you can feel, right, the device and sort of it has been showing some promising results so far. So I think if that doesn't turn your head, I don't know what will, honestly. So kind of prosthetics are talking their own. I think you can kind of go on about it forever. But in our case specifically, the child is 12, right? I think that he's cognitively ready to probably start thinking about how to use or understanding some of the practicing with a bioelectric, but would probably also fit him for a body-powered prosthesis that you can use more easily throughout the day, and probably also fit him for a passive prosthetic, something that he can use when cosmetic appearance is important. I mentioned very early on that we can do so. I talked about kind of before, right? The idea of letting the advancement trickle down to kids. And, I think that in some cases that's appropriate, but, I mean, you can see like we have the know-how to make some really exciting changes in people's lives. And so I think that it's worth it to do, in this case, some pediatric focused advancement in the technology. It would take a lot of activation energy, a lot of thinking for a very small swath of patients, but the impact is, can't be understated. So, okay, so we've done the surgery, we've managed the limb, we have great prosthesis. Is there anything more we have to do, right? It's like getting to the end here. There is, right? So again, the role of the psychiatrist, the child life specialist, the social worker, not only in managing the psychiatric concerns, but also helping the kids, again, navigate the different social spheres that they enter because of the amputation is extremely important. So there are a lot of narrative pieces on coping with amputation in the pediatric population, about how sort of the cause of the amputation or the urgency, the age, the stage of development, personality traits, the spirituality, all those things really play into how these kids will perform. And what our psychiatric and social work team do is they sort of help our patients and families wrap their mind around sort of all of these things and help them understand kind of the discrete role that they all play in the psychosocial development of their child. And then what they can do is they can help us categorize the different themes and organize them into sort of this manageable framework, right? And so sort of thinking of things as modifiable, non-modified, and this isn't a perfect schema, but this is what they do, and they help our kids, help our families, to help our kids kind of develop methods to improve the modifiable things and navigate the things that you just can't change in kids, right? Things that are more static, right? So how do kids do, right? I want to touch on that. And this was a piece from, it's a little bit dated at this point, but it was out of St. Jude's in Tennessee. Very well written piece. And in summary, children do well. And it's surprising, right? They highlight they have a less mature understanding of the world. They have no knowledge of what's out there to help them. They're in school, and school-age children are like extremely mean. I don't know if you've ever met a 9-year-old. Sometimes they can be, they're often at an age where maladaptive coping is kind of their go-to, right? Think of the idea of throwing a tantrum, right, to solve a problem, right? But somehow, as it goes with pediatrics, right, for the most part, they do just fine, right? Body image, peer relation, all those things are very crucial, right, to self-expression. But for some reason, the kids do very well. And the authors of the study weren't able to kind of identify, at least not in any way that I saw, that why the kids are so resistant to maladaption. I think in part, it's because kids don't have a fixed schema of sort of the way things are just yet. Every day they're learning something new. Every day something becomes real for them. Every day they figure something out, and this is just the way things are now. And so I think that because of that, being used to accepting things, kind of that idea of being more accepting than questioning, often probably makes even major life changes sort of just like a small bump in the road. For them, that's my inclination, not cited by anyone. So family counseling. So rolling to the end here. Kind of the last thing is that not only did the child lose their arm, but the parents feel like they lost their arm, or the caregiver feels like they lost a limb too. And so that's sort of one of the double-edged swords of pediatrics in general, right? The child always has an advocate. Right, someone's always there for them usually, and that's awesome. But in some cases, right, you end up treating two patients kind of for one injury or for one problem. You can get thrown into this relationship triangle that can be kind of tough to navigate. But I think that having respect for the dynamic between the patient and their caregiver, right, the child and their parent, for example, and being able to leverage that relationship in care of the health of the child, kind of recognizing them as a unit, and understanding how you've changed both of their lives can help you do a better job at one, helping both cope individually and then optimize the child's recovery. So yes, I got there. So you can't beat this one down enough. Trauma is the number one cause of morbidity and mortality in kids, right? The only surefire way to make a difference is to be conscious of prevention. Kids are not small adults, right? They're different. Consideration of the dynamic, the immature skeleton in this patient population is crucial. They don't end up having a lot of the same complications. They're different. You just have to think about them differently across the board. You can't do this one alone. PT, OT, psych, ortho, PMR, social work, the orthotists, prosthetists are all integral. And I hope that I've impressed that on you guys today. And then amputation in this population and in any for that matter, I think you simply just can't consider it as an ablative or destructive procedure. And I think we should try and think of it as sort of creation of the foundation for a useful and functional prosthetic, right? It's not that we failed, right? It's not that we weren't able to save the limb. I think that we should see it as just another reconstructive pathway for these patients. So surgical expertise, attention to detail, attention to the soft tissues, the bones and nerves, all those things are going to help to create a very promising future, and we can really do good things for our patients. So I'd like to thank Dr. Balicka, Dr. McPartland for their help and their feedback on this presentation. And I like to say, I stand on the shoulders of giants when I give these talks. I hope I just didn't look as awkward as that. So here are my references, guys, and just two questions in case anyone has none. We'll just sort of discuss these things if you'd like. Thank you.
Jomar, I was going to have two comments.
Yep.
So first is just nice job. That was great. And you mentioned that Dr. Balicka just happened to be on call for your case there. So comment one was, anytime you see a mangled extremity like that, Dr. Balicka is always on call. Feel free to call her anytime you want. And then the second comment was just on maybe a practical aspect of when those kids roll in. It's probably, it's relatively rare, but when they do come in and say you're the attending on call, I would definitely recommend that, when you go to the OR, that you formally involve vascular surgery and have them there and present, and make sure that they dictate a separate operative report and that you dictate an operative report. And it's probably not a bad idea, as long as it's safe to do so, is to try to just wash everything out and stabilize everything, and try your best, perhaps not to do an immediate amputation if possible, even if it is a really mangled extremity. Even if it's just to give yourself time to talk it over with vascular afterwards, the day or two after, and talk it over with the family and get to know the family. And then I would even heavily encourage you to formally consult two of your colleagues who also have a similar specialty or are in different groups, to formally consult and actually put in a consult note, or involve them when you're talking about doing a formal amputation. Because obviously these can sometimes be medical legal, and probably are often medical legal. So I don't think it hurts. This is a case to temporize things and phone a friend.
Right. I think that's absolutely right.
Well, I would certainly echo that. And I don't think even in a traumatic lower extremity, which you probably see a lot more, it's very rare that you would probably do a primary amputation, because as Steve said, the consequences can be significant. And I think, it's never probably an emergency, and it's always better to get other opinions just in these days of medical legal kind of concerns. The other thing is, this is obviously, you did a wonderful job. It's a very esoteric kind of, I can't, maybe I've seen one in 40 years, okay? But we certainly see the most common congenital amputation in the upper extremity is a transhumeral. And so we certainly have a lot of experience with kind of, using various prosthetics. And certainly there's been significant improvements, but from a practical standpoint, kids don't like to use them. Okay, keep it simple. That's what kids do, and they do remarkably well, you know, with a simple kind of device. Myoelectrics are great, and when they work, they're very nice. And when sensation works, it's great. But the downtime on these is significant. And when they're down, it's a problem. Because then they always need to go back to something,
Right, exactly. And yeah, you're correct on that. Especially, I think there was Dr. Billick was talking to me a little bit about the differences between the congenital and the traumatic patients, and them using their use of prostheses, and sort of the idea of, again, this very flexible schema and being born into having no limb versus having one and then removing one sort of changes the way that the kids end up using or wanting to use the prostheses, the stigma attached to it and so forth. So, but you're right. I mean, I have like a million GIFs in my hidden slides of kids like using their arms without prostheses. So it's not something that they certainly need, but it's certainly something that I think that can be very useful for them potentially.
I would echo on top of what Andy said. I think that there is a hard time with kids using them. I had a friend growing up at summer camp who had some brachydactyly, and he had a prosthetic extension, that made his hand larger. And he really didn't like using it. I wasn't mature enough to talk to him about it at the time, but I think that the prostheses, I think it's what Jomar was trying to raise today, is they've come a long way. And when you show people what things can actively do, because a lot of the early prostheses are just passive prostheses to get used to wearing it. And this idea of acceptance and getting psych involved, is obviously not a new principle, but I think that just the materials that go into it and the realism that they can create with the limb, and then the ability to actually control it and move it, I think hopefully will be a huge boon to ultimate acceptance, and it'll get easier and easier to use. I have no experience to speak to it, so we have to rely a little bit on what the literature said, stand on the shoulders of giants, as Jomar said, but I think the promise of this is amazing. I really do.
So, Jomar, great talk on something that's difficult to talk about because there's not a lot of literature. The literature on congenital amputations certainly shows that kids don't like to use prostheses, and it's probably related a little bit to the fact that they were born without it, so there's not the cortical mapping for it. That literature does include early myoelectric prostheses, although there's been nothing newer with some of the pattern recognition ones. So that would be interesting to see if congenital absence of a limb, if they like to use prosthesis. But so far, there's been large studies showing that they prefer not to. We used to just blame parents. So I think it's a little bit different when you were born without an arm versus when you lost it. And then also depends on what age you lost it on. I think in terms of how much we see this, I think it's out there more than you think. It's just the digits are more common. So not a day goes by that I probably don't see at least one partial finger amputation. You guys probably see that in the ER quite a bit. But as you move up the limb, you're going to not see it as much here. One, because we're not a replant center, and two, it's less common as you get further up the limb. So, one of the reasons we're probably not seeing a ton of it is the fact that we're not a replant center. They're not going to come here in the ambulance. They're going to go to Newark, or they're going to go to CHOP, and they're going to skip over us. So it's pretty rare you're going to see that show up on our ER.
On the off chance, we'll be sure to give you a call.
Unless it's a leg, then call Dr. Adelson.
All right, guys. Thank you a ton for your attention. Appreciate it. No more questions. Well, we're done.